So we're gonna have a lecture on cardiovascular screening and the collapsed athlete today. Dr. Kim from Emory, he's the chief of sports cardiology there, team cardiologist for several of the pro teams, and Georgia Tech and Emory. And Chad Asplund will follow him with the collapsed athlete, former AMSSM president, currently at Mayo Clinic, more often in Minneapolis, medical director, USA basketball junior teams. And I'm coming from, I was the fellow representative last year's fellowship class coming from Emory, and now will be in South Bend affiliated with the Notre Dame fellowship there. Just a couple housekeeping things. This is just meant to be an adjunct to your already curriculum going on at your program and help assist with the CAQ exam prep. And then please mute and then submit any questions in the chat function. And I will ask questions if there's time for Dr. Kim at the very end of his 30-minute mark, 1:30, and then Dr. Asplund at the end of his time. So without further ado, I will go ahead and let Dr. Kim get started.
All right, let me just share my screen. Okay, can everyone see?
309-301. Is that what it was?
Everyone can see my slides, I'm assuming so. Let me know if not. I'm going to get started. Well, thank you for that introduction, Heather. It's been phenomenal to get to know you over the last year, and we miss you at Emory, but congratulations on your move up. And I just want to say thanks to AMSSM for putting together this series, and specifically the emphasis on some important sports cardiology topics. We all recognize that the care of the athlete from the cardiovascular perspective remains a team approach. It's not just the sports cardiologist. It clearly involves the primary care sports medicine physician and really others as well. And so with that, it's really important to go through some key points about the cardiovascular pre-participation exam and just screening methods in general for young athletes in the attempts to avoid cases of sudden cardiac death. Sorry. I do have some disclosures, some relations with some athletic teams you heard about. You can see my research fundings, but really no conflicts relevant to this talk. So I have several primary objectives for you that you take away upon conclusion of this talk. Number one, I want everyone to appreciate the epidemiology of sudden cardiac death in athletes. We all know it's rare, but let's get in a little bit to the weeds because it's a little bit more complex than that. Of course, the primary focus, I want to have everybody understand the pre-participation history and physical. And I'll throw in a little bit of pearls as well. I think probably everybody has some familiarity with the 14-point American Heart Association history and physical. But I do think there's some key nuances that can make all of our pre-participation history and physicals more comprehensive and therefore more efficacious. It's important to get into the controversy of the pre-participation ECG. Of course, that could be a whole hour at least of a talk. So we're just going to touch on some of the highlights. And I do believe you have another talk on athletic or just ECG interpretation from Dr. Dresner. So I'm not going to get a ton into some examples, but we'll go into some what I think are critical normal ECGs that everybody on the sports medicine side, whether you're a cardiologist or not, should recognize. And then lastly, just have a little bit throughout. So this primary objective, I think, is sprinkled throughout the whole talk. Have everybody appreciate the complexity and challenges with this. Understand this is simply not a perfect science, and there's always challenging cases. So with that, I'm going to start off with two cases, which I think highlight the challenges of this, as it relates to the pre-participation exam. These are two not made up cases. These are real life patients of mine, and I think they highlight some important points. So the first, this was an 18-year-old athletic runner. She was just starting cross country at a university, local university, no symptoms. So interestingly enough, she was referred for an abnormal family history, and you could debate the merits of concern for a paternal grandfather's sudden death at the age of maybe 48. We don't know the cause, but my colleague was a little bit on the conservative side, which is not unreasonable, and sent them in for a more formal evaluation for that. probably as you would expect for a distance runner, normal to low blood pressure, petite. Her cardiac exam was normal. So you can imagine my surprise with her ECG just based off that family history. I was expecting, okay, well, this will be normal ECG and we'll move on. And clearly everybody recognizes the primary problem. This is an ECG normal sinus rhythm, but you can see the diffuse infralateral T wave inversion. So these ST abnormalities in the inferior leads, and then again, moving from V3 to the lateral leads across the precordium. So clearly abnormal, warrants for further evaluation. So we're gonna get back to this case. Case 2. This is a 19-year-old African-American man, college football player. Interestingly, we of course have some referrals just based off of our research. You're not always going to catch everybody with normal echoes. So this was captured a part of a research study, and there was mild aortic enlargement. So given that finding, was referred for a little bit more of a clinical evaluation. Other than that, the family history was negative. This was actually obtained separately, not necessarily from our clinic up front. Physical exam was normal, and the athlete was a non-lineman, was a member of the defensive secondary. So just to skip ahead, this was a cardiac MRI and MRA that this athlete underwent, and we can see the issue, the dilated aortic root, measuring about 42 by 43 millimeters. That's enlarged, so anything above 40 millimeters is considered enlarged. Based off of this criteria, there's a whole separate question of sports eligibility, which is not a part of this discussion, but clearly affirming the diagnosis. So we're going to get back to this case as well. And again, that athlete had a normal history. So let's get to the epidemiology of sudden cardiac death in athletes. And here we get to our first controversy, which is what is the exact incidence of sudden cardiac death for young competitive athletes? And the reason why it's controversial is because it's a rare event. So all of us recognize that when you're dealing with rare events and you're trying to calculate incidence of disease, that calculation can be fraught with error because cases are so rare in an overall count. And so you can have issues with both the numerator and the denominator. Of course, when you think about the denominator, there's some key questions. What population are you talking about? Are we talking about young competitive athletes? Are we involving older recreational athletes? Therefore, that also introduces the population overall, again, whether it's a sanctioned athlete versus a non-sanctioned athlete. Interestingly, some studies will capture cases based off of timing that's not even related to exertion. So it could be any athlete that dies at any time suddenly would count as part of the denominator. So again, there's different ways that you can calculate that can clearly make a difference. And then perhaps of even more importance is the numerator. So how are you calculating cases? Of course, that's going to be very dependent on your time frame. And there's this very interesting epiphenomenon, which is whenever there is a case of sudden cardiac death in an athlete, they tend to come in clusters, which is quite interesting and certainly doesn't have a great explanation. But nonetheless, if your capture period incorporates a time where there's a cluster, well, clearly you can inflate what potentially would be the accurate incidence of sudden death. So this is probably the most cited study. This is an Italian study, and it's really based off of this study for which the Europeans mandate pre-participation ECGs. This is over a 30-year time period this was actually captured the time period after the mandate for pre-participation ECGs. This was the incidence before the mandate, and what they found was a 90% reduction in sudden death after the mandate. But again, there were some challenges to this study design. If you look at NCAA athletes, of course, everybody knows Dr. Harmon and Dr. Dresner. These data come from their NCAA registry published in 2015. And again, even among this data set, it was quite interesting, showing a higher incidence of sudden death in various athletic cohorts, such as those who play basketball at the collegiate level. This is another kind of review article from Dr. Harmon, again, just really citing probably what's an accurate incidence in terms of looking at a general ballpark figure between 1 in 40,000 to 1 in 80,000. But I just show this slide again to highlight that it's really hard to calculate the incidence because of the overall rarity of the event. And it's also because of that makes for best practice management considerations quite challenging. And certainly when introduced to the debate of pre-participation ECGs, that's why that debate is so difficult to answer. So when we talk about etiologies, all of us on the sports medicine side are familiar with each of these diagnoses. This is a review article actually from Sanjay Sharma's group from the UK. And I like this because it separates things into bins. So it's you don't necessarily have to memorize diagnoses so much as different categories. Of course, when you think of structural cardiac pathologies, HCM or hypertrophic cardiomyopathy is a diagnosis we all think of. You think of congenital coronary anomalies, Marfan syndrome, and perhaps ARVC, which stands for arrhythmogenic right ventricular cardiomyopathy, some of the more common causes. Acquired cardiac abnormalities. I'm going to highlight specifically the first one, infection myocarditis. So we're not going to talk about COVID-19 today, which is probably everybody's relief. But I can tell you, I'm sure we've all thought about the fact that unfortunately COVID-19 is here to stay, and it's going to impact us on the sports medicine side and clearly integrate itself into how we think about the pre-participation evaluation, number one, symptomatic athletes. And unfortunately, we're going to have to keep a close eye on cases of sudden arrest, given the concerns of underlying cardiac injury in athletes with COVID-19. So myocarditis is clearly a highlighted diagnosis that we need to be mindful of. And then of course, commotio cordis, other toxins, drugs, hypothermia, et cetera. And then your primary inherited arrhythmic syndromes like long QT syndrome or Wolff-Parkinson-White. So these are the diagnoses that are all running through our head whenever we're evaluating athletes. And so, of course, we know that the pre-participation screen at its core is certainly mandated by the American Heart Association and by the Europeans as well. And I suspect many of us all know that the big difference is the recommendation, or lies in the recommendation for a pre-participation ECG, where the Europeans mandate the use of the ECG, whereas here in America, we do not. It's based off that Italian study from Dominique Corrado that I mentioned as to why the Europeans and the Italians kind of led to that recommendation in Europe. It is important to recognize that, yes, the ECG does improve the ability to diagnose various conditions, such as an asymptomatic athlete with Wolff-Parkinson-White pattern. You will recognize the delta wave on the ECG, and that would never be diagnosed based off a physical exam in an athlete who otherwise didn't have symptoms. Similarly for long QT, and even for diagnoses potentially such as hypertrophic cardiomyopathy if you can't pick up the heart murmur. We're going to talk a little bit about that controversy as well. But first, I want to spend a good bit of time going through the 14-point American Heart Association history and physical. So we're not going to go through each of these. Everybody probably already knows these because I'm sure all of us have gone through this at some point, and it's clearly easily referenced and accessible. But I think the key point here is one of the, I think, limitations of the history and physical isn't so much that it's poor, it's a poorly performed 14-point history and physical. And you can do one of these certainly in a short period of time, particularly in an athlete that may have no symptoms with a normal exam. But it really is an art form to do this well, and recognizing that the patients that we're trying to perform this on are primarily young individuals who have low attention spans, are distracted, are trying to get out of there through physicals. We also have to recognize that they're young and they don't necessarily have the knowledge base that the rest of us do, given that we've been studying all of these symptoms and conditions for our entire medical careers. So I think it's really important that you spend the time. The worst thing to do is to say, hey, do you have any cardiac symptoms? And believe me, I think I've observed some of this in the past. And of course, the athlete's going to say no. Or just say, hey, do you have chest pain when you exercise? Believe it or not, you need to extrapolate it. You need to expand on that a little bit more. Use colloquial terms, a squeezing sensation in your chest, a tightness in the chest. Sometimes they may think of chest pain as like a true sharp knife-like pain versus when they're exerting themselves, if there's a pressure, which isn't really an uncomfortable pain, it's a pressure sensation, that actually is what we're really concerned about. So it's outlined in the HMP, but it's really important to get in on these symptoms. Of course, if there's a positive for anything, you want to get more into the weeds, particularly when they say, oh, I'm dizzy when I exercise. You know, many times it's not really a concerning dizziness, but you got to get into the weeds and go through those symptoms in detail. Palpitations. I guarantee you that most young individuals have no idea what a palpitation really is. So don't ask about, hey, do you have palpitations when you exercise? You want to describe it really at its simplest form. Use terms like racing heartbeat, flutterings in the chest. I mean, all these things that almost sound silly to you, but can really help get to an underlying symptom from from the athlete. So it's really important to go through these symptoms in detail. And similarly for the family history, if you go through this too fast, it'll fly right by their eyes. Meaning, do you have a family history of hypertrophic cardiomyopathy, long QT syndrome, dilated cardiomyopathy, ARVC? They can't process that because they've never heard of the conditions, and it's going to be a waste of time. I have certainly had instances, which I promise I'm not making it up, where I'll say hypertrophic cardiomyopathy. Oh no, I've never heard of that. Is there anybody in your family who was told their heart was abnormally thick at a young age? Oh yeah, that has happened. So sometimes breaking down the conditions to its simplest form can pick up on a condition. I ask about, do you know anybody in your family who's young who has a pacemaker or a defibrillator placed? Sometimes that can bring up some of these syndromes. Ask about even conditions that aren't on here, like anybody in your family with a problem with their aorta, that was diagnosed at a younger age. Ask about strange deaths, drownings, single vehicle car accidents. Occasionally, perhaps you could pick up a long QT syndrome with a drowning. So you really just want to be as detailed as possible. And certainly not to say that the history and physical is perfect. It definitely is not. But at the same time, carefully performed H&P can be quite advantageous. So what about this debate about ECG screening for all? And again, we could spend a whole hour going through this. I just want to touch on some of the challenges as it relates to why we don't mandate ECG screenings here in the United States. Cost effectiveness, and again, there's some studies that have looked at this, but it's really a hard, I think, subject matter to get at in terms of proving cost effectiveness. Medical legal concerns. Of course, false positives, we're going to talk about how that's gotten much better over the years. And the two most important things, and probably the unfortunate reason why this controversy will never go away, is do ECGs actually improve mortality? Do ECGs save lives? And the reason why that's really going to be hard to answer is, as we get back to the beginning of the talk, we're talking about relatively rare cases. So the total number of athletes that you need to perform a randomized trial to look at ECG versus H&P alone is enormous. You need to have all of these techniques standardized. Who's reading the ECGs? Who's paying for this? So just those issues alone, you can recognize that this is really an unrealistic randomized trial that's going to happen anytime soon. And so unfortunately, we have a lot of observational data that come out, and certainly these are valuable studies, but there's always that primary limitation. And as mentioned, we do recognize that the ECG will pick up diagnoses that the H&P could miss, but that's the ultimate question: is, are you actually saving a life in that particular instance with that athlete that you picked up that condition? So we think these are going back over the years before I was even actively involved in the sports cardiology business, the evolution of ECG interpretation criteria. And I have to give Kim Harmon, again, courtesy for this. This is the slide that she used once, and it's just a phenomenal slide. And you can see all the different iterations of athletic ECG criteria that have evolved over the years. On the bottom, the improvement in false positive rate. And we'll focus a lot more on the international criteria rather than going back through some of the prior iterations where false positive rates were high. And you could again make the point that 1 to 2% is still not perfect, right? I mean, that's a high false positive rate for something that you're trying to argue you would mandate use in. Well, here are the international criteria for ECG interpretation in athletes, published in 2017. It was an update of the Seattle criteria. It took into account data from Sanjay Sharma's group, with a lot of publications and studies looking at some of these borderline ECG findings. We're not going to go through each of these. We don't have time. I did want to just touch on a few ECG patterns that, again, I think you'll hear again from Dr. Dresner, but are really important to recognize as normal, because for a non-athlete, many of these, or some of these patterns would not be considered so normal. So if there's one take-home point that you want from athletic ECG interpretation, is that isolated high voltage is normal in an athlete. And this is even a driving home, a point to drive home for cardiologists. I don't get as many referrals, thankfully, anymore from general cardiologists who are worried about HCM with an ECG that looks like this. I think we're more used to understanding that this is normal, but it's really important to note that this is a completely normal athletic ECG finding. And you can see the arrows pointing to the tall R waves across the precordium. It correlates quite correlated with true LVH. And a large percentage of athletes, no matter what registry data set you look at, will show a very high percentage of athletes who demonstrate isolated voltage criteria. You have to have abnormal findings that actually make that voltage criteria pathologic. So this is not considered something that, again, you need to have something that's truly borderline or abnormal to make this abnormal. That isolated voltage is always considered normal. It's not a borderline ECG criteria finding. Similarly, incomplete right bundle branch block, as depicted here in V1, this RSR pattern with a QRS duration that's short of 120 milliseconds, typically between 90 to 120 is where we typically call that. That's normal for anybody, whether you're an athlete or not, but we just see it more commonly in athletes. And it's really an electrocardiographic manifestation of the athletic heart, the enlarged RV that we see specifically in dynamic or endurance trained athletes. We've shown in published data, this is back when I worked with Aaron Bagish's group, that even complete right bundles in the data set of collegiate athletes that we looked at was actually normal. We didn't find any pathology. Now, that was relatively small. It was over 500 athletes, and we didn't have a ton of complete right bundles, which is that RSR pattern greater than 120 milliseconds. So that's considered a borderline finding, meaning it's a yellow box. So potentially that's something that you could refer on to a cardiologist just to get the green light. And then if you add on something else in that yellow box, then all of a sudden now that does require more evaluation. But an incomplete right, similar to the isolated high voltage, is always normal. And this is a pattern that you've probably heard about, certainly for those who have had talks from Dr. Dresner and Dr. Harmon, the presence of this specific early repolarization pattern in Black athletes. And this is the presence, I'll just show it to you, it's easier to recognize it. ST elevations with biphasic T waves. It's important to note you have to have that J point elevation, not extending beyond V4. So when you see that in a Black athlete, that is considered normal. It's actually, again, a green box finding. It's not borderline. And of course, to this athlete, you have some high voltage too. So this is a pretty classic looking athletic ECG. And it's definitely one that you have to get used to seeing. But based off of Sanjay's data from the UK over the years, we recognize this as a normal variant for an athlete. I want to get back to some cases now, the two cases I mentioned in the beginning. So this is the just one echocardiographic view of athlete one, and this was that young distance runner, again, with the very abnormal ECG. This is called the 4-chamber view. That's the right atrium, right ventricle, left atrium, left ventricle. Take my word for it, this is normal. These measurements here for wall thickness are normal. And these functional measures, E prime is looking at diastolic function, and this is a fancy measurement. It's called strain, looking at normal systolic function of the heart. This is all completely normal. So here we have an athlete who had a very abnormal ECG, but normal imaging. And for this instance, this athlete requires surveillance, imaging, and evaluations every year. They're cleared to participate. They don't leave with a diagnosis of anything pathologic. But it just shows that even the abnormal ECG sometimes don't necessarily equate to something, a true pathologic diagnosis. The reason why we do surveillance imaging in this type case is about 7% of the time, abnormal ECG with normal imaging can evolve to something in an athlete over the following anywhere from 2 to 10 years roughly. And so we have to track them, and that's our practice, certainly for competitive athletes that we take care of with that type ECG pattern. So the follow-up for this one, I think, is a really important take-home point. So remember, this is the young athlete who had the enlarged aorta. Everything was normal. ECG was normal. And this athlete was now brought into my clinic. And we were doing the interview. The athlete's family was in the room. And of course, I reviewed everything again. So we went back and talked about family history. Oh, well, by the way, turns out there was a family history of Marfan syndrome not previously disclosed. So again, this is actually a horror story, because you can imagine how we were all feeling like, oh my gosh, like this was an athlete who was actually already participating and potentially had this diagnosis out on the table. But it just shows, again, and this is not a fault of the history and physical that was performed previously by a colleague or anything else. It just shows, again, that whatever we do, it requires careful detail, and nothing is perfect. And in this specific instance, clearly the family history, if disclosed properly, would have brought up the appropriate concerns and led to the imaging and the identification of the aorta. For those who aren't familiar with Marfan syndrome, genetic condition associated with enlarged aortas as well as other, it's a connective tissue disorder. And of course, with that enlarged aorta, it's weakened and there's concern for potential tear aortic dissection. And for most instances, certainly in football, if this turned out to be Marfan syndrome, this would be an immediate disqualification. There would be no shared decision making with that aorta with this condition. Turns out this athlete actually did not have Marfan syndrome after the genetic testing, but it just raises again some of the issues that can come about with pre-participation screening. And one last point, I show this again, this kind of jumps on the point with case number 1 about how dynamic everything is. This was a recent study from Dr. Sharma, as well as a colleague, Dr. Anil Malhotra, again in the United Kingdom. This is a study of almost 11,000 soccer athletes. These were older adolescent kids screened through the English Football Association. They all have to have a mandated ECG, echo, and history and physical. And these are data that were accrued over this 20-year period. Very detailed evaluation up front, just showing that these were how many diagnoses that were picked up with diagnoses that could have potentially been associated with sudden cardiac death based off this very detailed protocol. But there were many that proceeded onward. And unfortunately, after the screen, there were actually 23 deaths, which included 8 cases of sudden cardiac death. And this, again, remember, was after this very detailed evaluation. And 7 of those 8 cases, cardiomyopathy was diagnosed, and 6 of them had had this very normal evaluation. And you can see this is just a sudden cardiac death incidence based off this cohort, which is certainly higher than what you would expect based off of other reported data looking at incidents. These are the cases. You'll note hypertrophic cardiomyopathy being one of the more common diagnoses, but all of this being clearly, very concerning diagnoses that were not able to be diagnosed at the age of 16. And it certainly does not mean the diagnosis was missed. What this really says is that these are very dynamic conditions. And we know that with these genetic cardiomyopathies that over time, the heart can progress from very normal looking to very abnormal looking. Shows the very fluid state at the age of 16, but again, really emphasizes the point that the pre-participation evaluation also is not something that is a one and done, particularly if you're doing these for the younger athlete. What's the appropriate time to repeat? That's certainly an open-ended question. But again, I just brought this study into this discussion because it's really important for all of us to recognize how this is clearly not pre-participation screening is unfortunately not always black and white. And again, just showing that the initial screening results were negative for 6 of those cases. So to conclude, take-home points. Again, let's get back to the primary objectives of the talk. Always remember, sudden cardiac death is rare. And of course, that's fantastic for us. We would hate if this was a common condition, but that's what makes the process of screening so challenging, and certainly what makes best management practices very challenging as well, and why it's going to be very hard to ultimately say that ECG screening actually improves what we already have in place. And it's important to remember this. I tell this to the teams I work for all the time, even whenever we've done echoes in the past. Best screening practices never eliminate all tragic cases. Screening is never 100% sensitive or specific. We wish that were the case, but it just isn't. And there will always be cases that will happen, unfortunately. A careful and detailed history and physical works. Again, I intentionally didn't give you what side of the fence I was on as it relates to ECGs versus not, because I think it's important to recognize the value of both. And there is value in a good history and physical, and hopefully some of the cases I presented kind of emphasize that. But that also doesn't discount the fact that there are limitations. And clearly a screening ECG can help identify more cardiovascular diagnoses. The ultimate question though is, does this reduce or improve mortality? And we don't know the answer to that. And so when you think about your screening practice using ECGs or not, certainly as you guys move on in your career, it does require very thoughtful logistic planning. Hopefully you have a cardiologist, a sports cardiologist that you can work with. And certainly if there is value in ECG and you have that expertise present, then there's certainly nothing wrong with leveraging that. In fact, that is probably something I would recommend. It's whenever those logistics are not in place that just ECG screening, I think, can get individuals into trouble as it relates to Paul Thompson's term of diagnostic creep, which means over testing and not understanding actually what you're doing. Thank you very much. Happy to take questions. Looks like I'm right at my time. There's my Twitter address. For those who were interested or are interested in sports cardiology topics, we did have our virtual care of the athletic heart. You can still actually get the content. And for FITS, it's free. So look up this website, ECG education, cardiopulmonary exercise testing. We had a great panel discussion on COVID and exercise. Anything that's free is willing to check out, but I think certainly there was much of this core curriculum that is in line with your guys' educational needs. And with that, again, sorry for the delays up front with the IT stuff. I'll stop there. Thank you.
Thank you, Dr. Kim. Definitely appreciate your talk, and that was awesome. I don't see any questions yet, but I do have, I'll just ask you one question. I know
Sure.
you have somewhere to be as well, but what do you think, I know you stayed away from COVID, which is nice, but what do you think the cardiovascular screening protocol, specifically relating to high school athletes for return to sport? You know, we know NFL, NCAA, the pro leagues have resources, but we also know there's asymptomatic COVID cases that still develop cardiomyopathy. Do you have any thoughts about screening for those athletes?
It's a great question. You have to think about healthcare resources, healthcare expenditures. What can you do? Recognizing that we still don't have the data, right? So based off of our ACC-sponsored recs about the this was in JAMA Cardiology in May about the very conservative screening protocol. We still don't have the data to say that's too much or too little. What we do have are some high-profile cases that all you guys have heard about. We all have, of athletes who've been diagnosed with myocarditis, which I just think affirm the need for continued conservative screening practices and taking this seriously. And so I actually think your question gets back to the public health part, because if you can't control spread, and we rely on our public health colleagues, Doctors Fauci, of course, Birx, you name it, all of our states have somebody we can rely on. We have to have control of the spread of infection, because if you don't, no matter what your screening practices are, you're going to have uncontrolled cases and you're going to have cardiac issues. And I think that's really relevant for high schools, because yes, not every high school can have access to this. And certainly you think about health insurance, I mean, all these very real concerns that are out there. And I do think that has to come into play as it relates to competing sports at the high school level and what's going on in the community. Because if you don't have the cardiac piece in place, and I think that's what I'm trying to drive home, is that playing sports probably, I don't know, it should be driven by the question of cardiac injury. We've known about this for months. We obviously have the concern and we screen for it. I think it still gets back to how uncontrolled is the infection. And that should really drive, I think, if you should proceed. And then thinking downstream about what the resources are, of course, still important, but it really gets back to that point.
Thank you.
All right, I'll pass the mic on to Dr. Asplund.
Thank you.
All right, thanks, guys.
Are you ready for me?
Yeah, let me just say a few things about you. I introduced you earlier, but let me just do it while you're present. So this is Dr. Chad Asplund. We're so grateful to have him present. He's the AMSSM past president and currently at Mayo Clinic, mainly in in Minneapolis, and currently the medical director of USA basketball junior teams, as well as team physician for US ski and snowboard and US hockey. And very involved with AMSSM and has a lot of research that's previously published and interest in exercise-associated collapse, sudden cardiac death, and sleep medicine especially. But without further ado, I'll let you go ahead and get started. Thank you, Dr. Asplund.
All right, thank you. Let me see what I need to do here to, all right. So my talk will be a little bit shorter and a little bit more practical. So focused really on something that can be really of use or utility to fellows and new sports medicine doctors. So we will talk about the collapsed athlete. Things that we hope to do by the end of this talk is to become familiar with different causes of collapse and then learn how to approach the collapsed athlete and how to identify the different etiologies of collapse, and then to deal with those in a way that will be safest for the athlete. So athlete collapse is generally pretty uncommon, but when it does happen, it is scary. It does get your heart rate going when you're on the sidelines, but it can indicate a severe life-threatening condition. So it is important to really be able to rapidly determine what might be the cause of this collapse, put a treatment plan in place, and marshal your appropriate resources. The things we'll kind of talk about today will be the cardiac conditions, opioid overdose, heat injury, asthma, anaphylaxis, as well as sickle cell trait, exercise collapse associated with sickle trait, or ECAST. So risk factors for collapse, and we've known this in a lot of our data, is those transition periods, kind of when you go from a summer to a preseason. If you've been injured and you're back for you're trying to get back into sport for a period of time. If you start with a lower fitness level, extremes of temperature, either really hot, really cold, dehydration, underlying illness, certain medications, especially those that speed up your metabolism, such as stimulant medications, caffeine, some of those weight loss supplements or fat burners. Family history of sudden death. Dr. Kim just gave a great overview of sudden cardiac death, but many of those can be genetic conditions, Marfan's disease, hypertrophic cardiomyopathy, long QT, those sort of things. Personal history of collapse. If you're someone who has had a exercise-related collapse before, that really should get you thinking about maybe there's an underlying condition. Timed or testing sessions. We see this a lot in the military. We see this a lot in those strength and conditioning led sessions where athletes can't just stop if they feel badly. They're pushed to go past their limit, or they're motivated to push to a certain time to meet a qualification for a military school or for a graduation or for something like that. So all of these things can contribute to collapse. So the biggest thing to really sort of differentiate when you're thinking about collapse is the athlete responsive or unresponsive? And so that's the immediate first tree that when you see an athlete, you want to make that differentiation. And so your unresponsive things will be your cardiac conditions as well as your opioid conditions. Your responsive ones will be your asthma, which they'll be responsive initially, and if they get to a point where they stop breathing, then they become unresponsive. Anaphylaxis, heat illness or injury, ECAST, or then just simple exhaustion can be your responsive causes. So we'll talk initially about cardiac collapse, and so you're going to respond. The athlete will be unresponsive. They won't have a pulse and they won't be breathing, and so this is your true cardiac emergency. The way you want to respond to this is simple: call 911, activate your cardiac emergency action plan, start CPR, get your AED. There have been plenty of studies that show that if you can get an AED to the patient within 3 to 5 minutes, your survival is much higher, and that for every minute that you delay getting the AED, survival will drop by 10%. So the AED is very important. Dr. Kim went over a whole bunch of information on sudden cardiac death. This is just a nice slide that I think kind of hits some of the main actors, and I know he just touched on those, but hypertrophic cardiomyopathy, sudden unexplained death, coronary artery anomalies, myocarditis are all sort of the big ones to think about. Your arrhythmogenic causes as well. And so those are the underlying causes that may get you to cardiac collapse. But again, it's an unresponsive patient with no pulse and not breathing. Opioid-related collapse, you might think, well, really, this has no room in athletics. Why are we even talking about this? But we'll show on the next few slides that prescriptions for opioids are way up. Abuse of opioids in the young high school, college athletic population is also up. And there have been several profile cases of athletes dying because of opioid-related collapse. Again, your patient is going to be unresponsive when you respond. There will be no breathing and their pulse may be shallow. Again, you want to activate your emergency action plan, call 911. You also want to administer your nasal naloxone. And so we have started stocking in our sideline kits and our emergency kits Narcan nasal spray, because it's a lot better to give someone nasal spray if they didn't need it. You're not really going to hurt them, but if they do need it and they are having an opioid overdose, you definitely can save a life. You certainly then want to get your AED and move along with your emergency action plan. So Tyler Skaggs is one of the most recent athletes to die from opioid overdose. He was a California Angels player that was found dead in his hotel room just before a game while on the road. And it was an article in the paper today which just showed that one of his medical staff was actually the one supplying him illegally with those opioids. And so a tragic, sad story, but had there been someone that responded with some Narcan in a timely fashion, he may still be alive. You can see here, if you look at overdose deaths involving opioids, sometime around 2013, the numbers just skyrocketed. And this does correspond with JCO's, pain as a vital sign, which, definitely showed that people paid attention to it, but then there was a belief that we had to prescribe things for pain control. And so this is the general population, but certainly our young athletes kind of mirror the population. And certainly there are many areas in the country where opioids are a huge deal. Asthma-related collapse is another thing that you can see. Initially, your athlete is going to be responsive, but if this persists or continues or progresses, then they may become unresponsive. The thing that is going to differentiate asthma from anaphylaxis is going to be your expiratory sounds. You'll hear wheezing. They may also complain of difficulty breathing, shortness of breath. Many, but not all of your athletes, you will know that they have asthma or exercise-induced bronchospasm, but you may not know that, and their first presentation may be an asthma attack. And so it is important to have an emergency albuterol inhaler in your kit. Again, most institutions, schools should have an asthma action plan. Each athlete should have a personalized asthma action plan as well. Again, if you have that collapsed athlete, you're going to want to administer albuterol. If you do have oxygen, you may want to administer that via face mask as well. And then you want to transport them to an emergency room. You don't want them to go on from an asthma attack to status asthmaticus on your sidelines. Times when this may be worse is if it's cool, it's dry, like in the winter or the fall, or if they've had a recent illness, or, I lived in Georgia for a long time, when the pollen is really, really bad or the allergens are really bad, you may have more asthma-related collapse. So when you look at, just a study of leading cause of death in athletes, cardiac is your biggest, but asthma is not, it's still in there in your fourth leading cause of death. And so it is something to think about when you do have a collapsed athlete. Anaphylaxis-related collapse is another one that a lot of people don't normally think about, but we are seeing more and more young people with peanut allergies. A lot of people are allergic to bee stings and things like that. The main thing that differentiates the anaphylaxis-related collapse from the asthma collapse it's an inspiratory respiratory noise rather than an expiratory noise, and they may complain of throat tightness or face swelling as opposed to chest tightness or shortness of breath. Again, there's usually an exposure to a food, an insect sting, but not always. Some people can have exercise-induced anaphylaxis, or they may have hot or cold anaphylaxis. And so definitely something to think about. Epinephrine is the hallmark of this treatment. Most of your athletes, if they do have a peanut or a flying insect allergy, should have an epinephrine auto-injector, in their kit or in their travel bag, but you may want to have one as well just for emergencies. Again, it never hurts to call 911 and activate your emergency action plan. So Zaire Smith was a near death from a peanut allergy following practice. He had gone off the court into the team area. He had a snack that he would normally eat, but it was prepared in an area that they were also using nuts, and he had an anaphylactic collapse in the training room area with the 76ers. And so this does happen to athletes, and there are more and more young people with peanut allergies or with allergies to flying insects. So if you look at the symptoms that you might see with anaphylaxis, sometimes it's the itchiness and the urticaria that happens first, which should then be the key to make you think about, this could be anaphylaxis. I should think about getting an EpiPen. You know, and then once you get to the angioedema flushing stage, now you're starting to have that swelling of the airway, and things are getting to a point where you're going to need to act, you know, rapidly. So think about it if you have pruritus and urticaria early, especially in the symptoms of a collapsed athlete. Heat-related collapse, I saw on the list of presenters that Doug Casa presented last week. He did I'm sure he did a tremendous job on heat-related collapse. We'll cover it a little bit here. Your athlete is initially going to be responsive. The key in this is that they're going to have altered mental state or confusion, and they will have had exposure to something that raised their core body temperature. Usually that's hot environmental temperatures, you know, but it doesn't always need to be 100 degrees. It could just be relatively hot compared to what the athlete is used to. You know, Bill Roberts put out a great article from several years ago on wet bulb globe temperature in Minnesota, and how if you have a sudden rise in your relative temperature, that could be enough to create a heat-related collapse. And then the other hallmark is a rectal temperature greater than 104 degrees. If you have a collapsed athlete and you're thinking about heat injury, you need to do a rectal temperature. It's uncomfortable and people don't like to do it, but you do need to get that, because that's going to be your most accurate piece of information. Again, the key in heat-related collapse, as opposed to many of these other ones, is that you need to cool them first, transport them second. The key to cooling is a cold water immersion. I'll have a picture of that on the next slide. You want to cool them down until their temperature is below 102, or they start to shiver, and then you want to transport them. Many young athletes, unfortunately, have died either in the ambulance on the way to the hospital or in the emergency room because they were not cooled ahead of time. So heat-related collapse, you want to cool first, transport second, which will be different than sickle collapse, which we'll talk about in the next set of slides. So here's Doug Casa and his group from the Stringer Institute in Connecticut demonstrating cold water immersion. You can see that the head is out of the tub and that they are watching him. You can see Dr. Casa here is looking at the rectal thermistor, and then you've got the recorder here. But that's definitely the best way to do it. If you don't have a cold water tub, you can use towels, you can use fans, but you definitely want to rapidly cool the athlete and then transport them after they're cooled. You're never a bad idea to cool someone if you're not sure. You can generally warm them back up, but if their temperature is too high and you don't respond, then they could die. And so you definitely want to cool first, transport second. Sickle-related collapse is something we're seeing more of. A lot more athletes now that we're testing, we're finding are sickle positive. Historically, those are going to be your African American or your Northern African ethnicity groups, but we are seeing it a lot in white people, as well as Hispanics or people from Spanish-speaking countries as well. And so it doesn't necessarily always line up with just your African American population. We are seeing it in a lot more patients. So this is going to be another case of responsive collapse. Patients are going to talk about cramps in large muscle groups. Sometimes what you may find is that they aren't actually cramping, but they feel like they're cramping because they're starting to occlude those small blood vessels that supply the big muscles like your glutes, your quads, your hamstrings, your low back muscles, those sorts of things. So they may actually have cramps, or they may just feel like they're having cramps with soft muscles. They will obviously be breathing and they'll have a pulse. The key on this is you want to start your high flow oxygen and you want to do aggressive IV hydration. If you have the ability to do that in your setting, whether that's sideline or whether that's training room, that would be the most beneficial. If not, get the high flow oxygen on, alert the emergency room ahead of time that you have a potential sickle collapse, and recommend that they provide high volume aggressive IV hydration. A lot of times they might go down a heat related path and delay this hydration, which is then going to allow more muscles to be occluded, more muscle breakdown. Now you're going to get into your explosive rhabdo, multi-system organ failure, things like that. So high flow oxygen, aggressive IV hydration, transport first, hydrate second. And so as opposed to heat injury where you wanted to treat first, transport second, you want to transport these people and then get the hydration second. This is just a schematic at kind of all of the different things that happens in a sickle cell collapse. You can see exercise is needed, but also local hypoxia, acidosis, increased temperature, and dehydration are all contributory. And so you can see if you're in a hot area at altitude or you're sick, all of those things can lead to this. And then you end up getting your hyperkalemia, your muscle breakdown, and all of that. So this algorithm is not in the algorithms that I'll have at the end, but I included it right now. So you have the collapse, they are responsive. If they're not immediate, you want to transport, but then again, provide your differential diagnosis to the emergency department, including possibility of ECAST and explosive rhabdo, and then you want to make sure that they start hydrating. If they improve immediately with your high flow oxygen, you may be able to continue to watch them, but I would do that under the watch of a physician. And so if you're having a protocol for your athletic trainer, you definitely want to see somebody in this scenario. So collapse due to exhaustion, that's kind of what you have left when you've ruled out all of those other things. Athletes still do get exhausted and they still are going to collapse. They will be responsive, breathing, have a pulse, normal temperature. And so you've kind of gone down your boxes and you've checked them out. Really, you just need to observe them and have them rest. Some of that can be due to deconditioning. Some of it can be a little bit of over vigorous training, but exhaustion is still sort of on your differential. We're getting close to the end, but I did include our list of endurance collapse as well as exercise collapse algorithms. These were developed with Fran O'Connor and Fred Brennan at the Marine Corps Marathon. And you can kind of walk through these. These are valuable tools to help you sort of understand what to do. And we used to print them out at the Marine Corps Marathon and would have them at the end of every bed, just in case you had a brain fart and you just needed to kind of work through an algorithm. It's better to do the right thing and take an extra second or two instead of go down the wrong pathway. So I've included these algorithms here. We've got our endurance collapse. Emergency cardiac care is essentially your ACLS or your BLS algorithm. Exercise associated collapse, again, that's going to happen when people collapse either just after the finish line or shortly after finishing a race, and you can walk kind of through that pathway as well. Your hyperthermia, your heat injury algorithm, you can follow that, and I know Dr. Casa really covered that. Hypothermia algorithm, again, I've included that just for your information. And then hyponatremia is something you'll see in endurance athletes, but that one's here for you as well. Last, hypoglycemia is here. And so really just wanted to be practical with a quick overview of collapsed athletes, how to rapidly differentiate between the causes so that you can put your treatment plan into place and that you can make the right decision quickly for the safety of your athletes. And so that's all I had. Hopefully we're closer to being back on track. I'm available for about 10 minutes for questions if anybody has any. Otherwise, I'll turn it back over to Heather and the group.
Thank you, Dr. Asplund. That was great. Definitely high yield information. I don't see any questions in the chat just yet. I'll go ahead and give you one though. Any tips or learning points that you've had over the years for new fellows out covering on their own or attendings covering on their own?
It definitely helps to go through the algorithms and to think about these things before the game. You know, we tended to review them, each one of those scenarios before a game, just to make sure that they were in the mind, and that way you didn't have to dig into the deep recesses of your brain to try to think of those. You know, when someone collapses, it can be a little bit scary when you're on the sidelines, especially if you're a fellow covering by yourself or a new attending. To be out on the sidelines to see someone go down and they're expecting you to be able to rush out there with an answer. And so kind of going through those things before a game, similar to the way you might, you know, practice your spine boarding or practice, you know, supervising the athletic trainers doing the spine boarding, just so you're all familiar. You know, I've seen every one of those in practice, and so the rapid identification is important. And so just kind of having that framework, responsive, unresponsive, and then working down that pathway can be helpful, especially when, you know, something happens and you've got to respond quickly.
Any other questions out there? I don't see any in the chat yet, but you can unmute yourself as well. It looks like we have no questions, and I know we are coming to the end of the hour. We've already there, but sorry again for all the glitches with the password and the link today, but we appreciate your patience. And if you were not able to view it, hopefully you can tune in on the YouTube channel afterwards. But thank you, Dr. Asplund.
Thank you for having me. It's been good. Hopefully I've been really impressed with the sessions that you guys have put together. A great resource for fellows and for new learners. So thanks for organizing the whole session.
Thank you. Thank you. All